Hi, my name is Dr. Onubra Abolade. I'm a medical doctor and microbiologist by training. I have put together a couple of videos for the sake of medical students or anyone who wants to just have a synopsis of infectious diseases by way of my training as a medical doctor and a microbiologist. I thought that would be a helpful idea. So the idea is to make the video short and summarized. Today we'll be looking at COVID-19, as we know that that's one topic that every medical student should have an idea of. Definitely the videos will not be exhaustive, but they're just to give us a general overview. Please feel free to let me know if there are other videos you would like to, infectious diseases, videos of infectious diseases you'd like me to put up. Thank you. Okay, so COVID-19. So COVID-19 is the name of the disease caused by SARS-CoV-2. So as we know, COVID-19 is the popular name on a lot of lips, but that's not the name of the virus. It's the name of the disease, and it's caused by SARS-CoV-2. So SARS-CoV-2 belongs to a family of single-stranded RNA viruses. The family is known as the Coronaviridae. They are known to infect mammals, reptiles, birds. Other members of the group include the MERS virus, which is the Middle East respiratory virus that was discovered in Saudi in 2012. And then there's the SARS virus, that was the severe acute respiratory syndrome, which SARS-CoV-2 happens to be kind of like a variant, not exactly, but very similar, which was also discovered in China in 2003. So this is also a SARS virus, but this is CoV-2, the CoV standing for COVID, and to differentiate it from the SARS that was discovered in 2003. So SARS-CoV-2 is the causative organism of COVID-19, like I already mentioned. So amongst these family members, it's the least deadly, but it's most transmissible. I guess that's why it's a very big deal. It's a very much worrisome infection as we speak. The others have a very higher case fatality rates. However, COVID is very much transmissible, especially with the advent of new variants. Okay, so generally they are known to have an incubatory period of about 14 days. That of COVID is about an average of 5 to 6 days, although it could span as long as 14 days. So the name COVID-19 stands for the CO. COVID is COVID, the 19. So the CO stands for corona, VI stands for virus, and D stands for disease. So that's the origin of the name. And the 19 is the year of origin. This time it was found in Wuhan. The first case was recorded in Wuhan, China. And the WHO declared it a public health emergency on January 30th, 2020. And then a global health pandemic at that point. As we know, a pandemic now is across many continents. At the time of March 11, 2020, it has spread to many continents and is currently in about over 200 countries of the world. So the epidemiology, as at 17th of February, today is the 20th, so that was about 3 days ago. There have been about 109, over that, but about 109 million confirmed cases of COVID and about 2.4 million deaths. The mode of transmission so far recorded and recognized are through respiratory droplets and through contact, which could be direct or indirect. So by respiratory droplets, so this could be released by singing or speaking to someone who is infected within a 1 meter distance. Then contact could be direct or indirect. So by direct contact, it could be by touching the person who's been infected and where the person has the respiratory or has the droplets, or indirectly by touching surfaces that have been touched by the person or that have been contaminated by droplets from the person. Okay, so individuals who are considered at risk for COVID-19. Now, this must not be mistaken as individuals who are at risk for complications. So these are different sets of people. So who are those considered to be at risk for COVID-19? Persons who are in areas with ongoing local transmission. As we know, certain countries have put bans on travel from certain areas that have been known to record high cases of the infection. So also healthcare workers, unfortunately like ourselves, and then people or healthcare workers who care for patients who have COVID-19, and then close contact of infected persons, so family members, for example, people who live in the same shared space and stay in the same 1 meter distance, and then travelers returning from locations where spread has been reported. So then the individuals considered at high risk for complications, so different from those at high risk for infection. Now these are those who are at high risk for complications. So they include older adults, generally people who are above 65 especially, and persons with serious underlying health issues like cancer, chronic kidney disease, chronic obstructive pulmonary disease, heart conditions like heart failure, coronary artery disease, cardiomyopathies. Also persons in immunocompromised states who are on steroids, who may have other diseases that compromise their immunity, and then obese patients with BMI greater than 30, body mass index greater than 30, and then patients with sickle cell disease have also been identified to be at high risk of complications, and also patients who smoke or have type 2 diabetes. So what are some common symptoms and signs? Probably everybody can give you an idea of what to think about when you're thinking of COVID. So some of the common symptoms recognized are fever, cough, fatigue, anorexia, shortness of breath, myalgia, body pain, so to speak. And other symptoms that have also been recognized include sore throat, nasal congestion, headache, diarrhea, nausea, and vomiting. A couple of people have actually been pushing to expand the threshold for testing for COVID-19 when these symptoms have been identified in patients beyond the cough and fever and all of that. They're actually asking or suggesting that other symptoms should be considered. And then not forgetting that patients can also be asymptomatic. Okay, and then some signs that can be picked up in such patients will include SpO2 that is reduced, probably less than 90. May not even be as bad as that. Respiratory rate that is higher than usual, maybe higher than 18 beats per minute, or it could even go as bad as 30 beats per minute. And then clinical signs of pneumonia may be picked, so such as when you do your respiratory exams, you may pick up signs like dull percussion notes, decreased air entry, reduced chest expansion. And I must make it very clear at this point that not every patient actually has pneumonia. Okay, so that's depending on the severity of the disease. So the signs and symptoms depend on the severity of the disease. So the WHO definition of patients with COVID could be a suspected case, so any person who is under investigation for COVID-19. A probable case is one who is suspected to have the disease for whom testing is inconclusive or unavailable. So when they are in low resource settings where access to the PCR test is unavailable and the person is under investigation or is highly suspicious, so it's a probable case. And then a confirmed one is one that has tested positive for the virus, which is the SARS-CoV-2 virus. So we must bear in mind that confirmed cases can be symptomatic or asymptomatic, notwithstanding the fact that groups of people can still transmit the infection. Okay, so for the management, I have put them into the history, examination, and then the actual treatment. So for the history, usually screening is done. So ideally, a screening form is filled, asking for symptoms of COVID that have been mentioned, the common and the less common symptoms, and then including the risk factors that we mentioned, the risk factors for infection of COVID, and then such as, of course, occupation, and then travel history, contact with positive cases. And then also we shouldn't forget the past medical history, because such people with underlying health conditions are at risk for complications, so to speak. So the response of these questions would influence what the doctors or nurses will do. So the idea of screening the patients is to identify patients who are at risk of COVID, and then will decide to warrant further investigation or intervention. So basically it involves syndromic screening, so asking about symptoms and then doing a temperature check, as we know that fever is one of the signs of COVID. So after screening, patients can be triaged. So triaging just basically involves determining the severity of the COVID symptoms the patient is presenting with. So the patients afterwards can enter the COVID treatment pathway, either as patients suspected as having COVID or having presented for other reasons. So sometimes patients present for other reasons, and in the process of clacking them, they show symptoms that suggest they may have COVID-19. So ideally, symptomatic patients should be separated from asymptomatic patients, especially when the tests have not been confirmed. So like I mentioned, there's a COVID-19 care pathway which patients should be put into. So the criteria for that would be a person enters that pathway after he or she, based on a standardized case definition, including assessment of symptoms, meets the criteria for a suspected case. So a patient who is suspected to have COVID-19 should be put in the COVID care pathway until test results show that he or she does not have the disease. So all persons with suspected, probable, or confirmed COVID-19 cases should immediately be isolated to contain the virus transmission. So investigations, basically, they are not very particular or specific for COVID-19. So as you know, the patient may be dehydrated, depending on, if the patient has been vomiting, has been stooling, has diarrhea. So the patient may be dehydrated, so you see signs of dehydration, depending also on the severity. And then the patient may be febrile to touch, so fever greater than 38 degrees, respiratory rates sometimes greater than 30 beats per minute. But these are not absolute signs, like I said, so you cannot specifically say you have to wait to see the signs to conclude that the patient is COVID positive. But these are some signs that kind of make your diagnosis stronger. So SpO2 less than 94 degrees saturation, that's the oxygen saturation. And then you picture signs of consolidation, of pneumonia. So other symptoms too may show signs, if you examine the other symptoms, depending also on if there are complications, which we would see along the way. So investigations have grouped them into diagnostic and supportive. So the diagnostic investigations would include the reverse transcriptase PCR, that is currently the most popular. A lot of people have talked about the antibody test, but it's more of a retrospective test to know if a patient has been infected in the past. So specimens commonly collected include the nasopharyngeal and throat swabs. So that's if the upper respiratory tract sample is negative. But some countries just go ahead and go for lower respiratory tract samples, which include expectorated sputum. So you ask the person to expectorate, cough, so to speak. So that's more like a lower respiratory tract specimen. But some countries use the upper respiratory tract specimen. However, If it's still negative and there's a strong suspicion, then they may go for lower respiratory tract specimens such as expectorated sputum, and then endotracheal expiration or bronchoalveolar lavage in patients who are ventilated, who obviously cannot expectorate sputum. So then other supportive investigations will be hematological investigations, so blood work, which may show white blood cells to be raised. So there may be neutrophilia, there may be lymphopenia, and then LDH may also be elevated. And then the active phase proteins like the ferritin, C-reactive protein may also be raised. And then D-dimer, this is a very quite worrisome marker, so to speak, of increased risk of mortality. So so the other biochemical tests can be done, like the liver function test, kidney function test, and then depending on suspicion or suspected complications, you could do an ECG if you're suspecting acute coronary syndrome, which is one of the complications among others. So then imaging, so chest imaging may be unremarkable. We must remember that chest radiography may be unremarkable in early disease, but later on may show bilateral consolidation. CT scan may show bilateral ground glass appearance, interstitial thickening, and parenchymal consolidation, with predelication, especially for the lower lobes. We must remember at this point that some of these features are not necessarily specific for COVID, but you may find them in other atypical pneumonia. However, when they are present, they can be helpful to assess the severity of COVID-19 disease, as some scoring systems like the CT scoring system has been developed, but we won't go into the details. So some of the complications which I mentioned, which could also influence your investigation, depending on your suspicion and the presenting symptoms or signs of the patient. Some of those complications, recognized ones, include pneumonia, like adult respiratory distress syndrome, sepsis, septic shock, DIC, cardiomyopathies, serious cardiovascular accidents, PEs, DVTs, acute kidney injury, complications from prolonged hospitalization, we shouldn't forget things like bed sores, even DVTs as a result of that, and then nosocomial infections. And then other complications like the lung barrier have also been noted. So treatment basically depends on the severity. According to the WHO, patients present in different categories. So 40% are usually mild, 40% moderate, 15% severe, 5% critical. I guess that's why we see that it has a lower case fatality rate than the other members of its group. That notwithstanding, we've recorded quite a number of deaths. So the mild cases are those without pneumonia, symptomatic. So basically you do symptomatic care, or even those who don't have any symptoms. But for those who have symptoms, then you basically, for people with mild COVID, they receive symptomatic care. So antipyretics, if there's fever and pain. So adequate nutrition, rehydration. Some countries even allow patients to undertake home care for COVID under supervision, as long as they are not elderly or do not fall into the category of those who are at high risk of complications, such as the elderly or those who have underlying health conditions, and as long as they are responsible enough to be able to check their vital signs like their temperature or their SpO2, and then report to the hospital if the symptoms get worse. So those who are who have moderate symptoms are those who have pneumonia. The SpO2 probably at this point is greater than 90%. Greater than 90%. These usually should be monitored for progression, monitored closely. And then severe disease, there's pneumonia present. SpO2 at this point is less than 90%, and the respiratory rate is about 30 beats per minute. So that's getting quite severe. These patients usually require oxygen therapy. And then the critical disease, these ones have complications, which I already listed. Sometimes they have cytokine storms, and then cardiac, hepatic, CNS complications, thrombotic disease. So management basically is, I've classified them into pharmacological and non-pharmacological. The drug which the FDA currently approves for the treatment of COVID-19 is remdesivir. It's an antiviral. However, some other drugs have shown potential, and they have in clinical trials. They include nebulized interferon and dexamethasone. So, as I mentioned, some patients have cytokine storms. Yeah, so they've been shown in clinical trials to help and improve mortality. But remdesivir is the drug that the FDA currently recognizes. And then sometimes antibiotics are given if there's a suspicion of a superimposed bacterial infection, so superimposed bacterial pneumonia or septic shock as a complication. And then some patients who are hospitalized need DVT prophylaxis, so they would have maybe low molecular weight heparin, enoxaparin, or pneumatic devices, and maybe TED stockings, especially if they're on ventilation or they're expected to be immobilized for a very long time. And then, so the non-pharmacological treatment would include oxygen, and then IV fluid resuscitation, but care must be taken not to flood the lungs, so there must be a balance, and checking their lung bases for palpitations to be sure that there are no signs of pulmonary edema. And then some patients may require vasopressin if they suffer complications of septic shock. So other non-pharmacological management include airway clearance in patients with evidence of increased secretions. So production, or those who have weak cough, and then so you could help them clear their airway, so you suction their airway, and then gravity assisted drainage. You could also teach them breathing techniques that would help them to drain their secretions. So there are also sleeping techniques that the patients can be taught, and then there's a place for rehabilitation afterwards. So after the patient has been treated and hopefully he or she recovers, the COVID-19 care pathway exits the point at which they exit the COVID-19 care pathway is as follows. So for symptomatic patients, 10 days after onset of symptoms, plus at least 3 days without symptoms. So the symptoms, i.e. respiratory symptoms and fever. So when the patient comes in and he or she is symptomatic, 10 days after presenting with the symptoms, plus at least 3 days without the symptoms. So these are very helpful indices, especially where there's no provision for repeat testing. Or for asymptomatic patients, 10 days after a positive test. My source here is the WHO Clinical Management of COVID-19 Interim Guideline 27th of May 2020. Please feel free to check it on the internet if you have the time to do so. So as a round off, just wanted to talk about the method of controlling COVID. So as we know, there are different methods. Some people would say you could do the primordial prevention, primary, secondary, tertiary prevention, but I have looked at it through the lens of the epidemiologic triad. So that includes the host, the environment, and the agent, which we know happens to be SARS-CoV-2. And then the environment would be contaminated surfaces, droplets, and then the host would be susceptible hosts like humans at risk. Like I mentioned, there are other animals like mammals and birds that are generally known to be infected by members of the coronavirus, but our focus here is human beings. So in controlling COVID, you could interrupt transmission of any of this through targeting any of these components of the triad. So for the host, your aim is to protect the host. So things like the vaccine that has been developed and is being promoted is one way, and then personal protective equipment, hand hygiene. The aim is to protect the host. And then environment, the idea is to modify the environment. So things like, so we said the environment involves contaminated surfaces, droplets, and then the surfaces around. So ideally you want to modify the environment, so you could disinfect contaminated surfaces. And then social distancing, where, remember we talked about the droplets within a 1 meter distance. So ideally you keep a 1 meter distance. And then things like ventilation, especially when you are doing aerosol generating procedures. That's for those who work in the hospitals. And then for the agents, so you either want to destroy or you contain the agent. So one of the ways of destroying, or so to speak, targeting the agent is through the recognized antiviral agent when there's a and then to contain it would involve isolating infected individuals. So thank you very much for listening. Please feel free to visit the WHO website for more information. I hope this video has been helpful. Subsequently, we aim to make the video shorter, and we look forward to your feedback. Please let us know what other topics you think that we can put together that will be helpful. Thank you for your time and have a good day.